Hello and welcome to today's lecture on lymphatic filariasis, or commonly called filariasis. So as you all know that lymphatic filariasis is a tropical disease. It is caused by parasitic worms called microfilaria. It is endemic in certain regions. To know the preventive and control measures, we need to understand what is lymphatic filariasis and why it is important. So it is an infection usually acquired in childhood and causes hidden damage to the lymphatic system. This needs to be remembered that it can occur in any age group, but it is usually contracted, the infection is usually contracted in childhood. Incubation period is approximately 1 to 2 years. That is, today where you might have got bitten by the mosquito and you might be displaying the uh, clinical symptoms or clinical signs 1 or 2 years later. So that needs to be remembered. So incubation period is a long incubation period. So lymphatic filariasis, the causes and treatment: it is caused by parasitic worms that live in the human lymphatic system. These parasitic worms are called microfilaria. So these worms are transmitted by bites of infected mosquitoes, which act as a vector for the disease. And then the three main species of parasitic worms that cause lymphatic filariasis are the three: Wuchereria bancrofti, that is responsible for almost 90% of cases. 90% of the cases worldwide are mainly because of Wuchereria bancrofti. The remaining 10% are by the two species of mosquitoes, Brugia malayi and Brugia timori. Brugia malayi and Brugia timori. So the main microfilaria are this Wuchereria bancrofti. That is, it causes 90% of the infection worldwide. So that is, then the other two are Brugia malayi and Brugia timori. Now it is transmitted by different types of mosquitoes. So as we know, malaria, Anopheles, dengue by Aedes, all these that different specific species are transmit specific disease. Lymphatic filariasis is a disease which can be transmitted by these three mosquitoes: Culex mosquito in the urban and semi-urban area. Culex mosquito in urban and semi-urban area. Whereas in rural areas, it is Anopheles which transmits lymphatic filariasis. And in endemic islands in the Pacific, where Anopheles density is less and Culex density is less, Aedes takes the responsibility of transmitting lymphatic filariasis. So need to be remembered. So the incubation period, it is about 8 to 16 months. 16 months is more than 1 year. So we need to be, I told you, the time period between entry of infectious agent to the appearance of the first clinical symptom is called incubation period, and that is 8 to 16 months, and sometimes it is also quoted as 1 to 2 years. So it has a long incubation period. So we don't know exactly how long it will take for a person to develop lymphatic filariasis after getting bitten by the concerned mosquito. So the periodicity, both the microfilaria of Wuchereria bancrofti and Brugia malayi, they occur in India. Brugia timori is rare, or it is not found in India. So the Wuchereria bancrofti and Brugia malayi both occur in India. They have a nocturnal periodicity. That is, they appear in large number at night, retreat from bloodstream during the day. So in the day, they are not found in the bloodstream, whereas they are found in the bloodstream in the night. So the maximum density is reported between 10 p.m. to 2 a.m. So if you need to do a detection of microfilaria in the bloodstream, you need to take out the blood from 10 p.m. to 2 a.m. So that is what the nocturnal density of microfilaria means. So it's a biological adaptation to the nocturnal biting habits of the vector mosquitoes. So even the mosquito has to bite at that time to take out the microfilaria and infect the others. So life cycle, it is a definitive host is man is the definitive host, intermediate host is mosquito. So through the mosquito it gets transmitted from one host to another host. So the adult worms, macrofilaria, are found in the lymphatic system of man, where they may survive for 15 years or more. For 15 years, a macrofilaria, the adult worms, can survive in human blood. During their lifespan, after mating, female worms, they give birth to 50,000 immature microfilaria per day into the blood circulation via lymphatics. So you can imagine 50,000 per day. 50,000 immature microfilaria are given birth by the macrofilaria which are present in the blood. So every day 50,000 immature, they may survive up to a year or more. So these 50,000 immature parasites may survive for a year or more. So some of these microfilaria may be ingested by the mosquitoes during their blood meal. During their blood meal, these microfilaria which are given birth by macrofilaria in the blood, these microfilaria, immature microfilaria, can just be ingested by any mosquito during their blood meal. So this is the life cycle, the reservoir of infection. Although filaria infection occurs in animals, human filariasis is not usually a zoonosis, not transmitted from an animal. The definitive host is man, from man to man. This is man to man through a mosquito, and not from animal to man. So if it is animal to man, it is called zoonosis. So if it is not animal to man, it's definitely not a zoonosis. In man, the source of infection is a person with circulating microfilaria in peripheral blood. In filarial disease, late obstructive stages, microfilaria are not found in the blood, and the minimum level of microfilaria which will permit infection is not known. We do not know. There is no dose relationship. It might be one microfilaria can cause disease, or it might be thousands of microfilaria can cause disease. We do not know how many microfilaria are known to cause disease. So epidemiological determinants, as we know, the agent, host and environment. The agent, as we know, the Culex, the vector for Bancroftian filariasis in India, Culex quinquefasciatus. Quinquefasciatus is the vector for Bancroftian filariasis. Mansonia, another mosquito, is the vector for Bruggian filariasis. That is Bruggia malayi. The Bruggia, if Wuchereria bancrofti is transmitted by Culex, whereas Bruggia malayi and Bruggia timori are transmitted by Mansonia, the mosquitoes Mansonia. The Culex breeds in polluted water. Culex breeds in polluted water. Mansonia is associated with aquatic plants. That is, it breeds in a place where aquatic plants are commonly found. So the host factors: man is a natural host. All ages are susceptible for infection. No age, we cannot say kids are more or more affected or not. So the infection rates rise with age up to 20 to 30 years and then level off. So infection rates are generally common as the age a person from a childhood, it increases 20 to 30 years, and then they come to a standard, a stagnant infection level. It is neither increases nor decreases. Gender, microfilaria rate is higher in men than in women in most endemic areas. It's more common in males. It's more common in males. So one thing which need to be remembered is it is more common in males. So, and then the migration, Okay, not so important, but it has led to the extension of filariasis in non-endemic areas. Migration of the people from one place to another has led to the extension of microfilaria in areas which were previously not endemic. Endemic, again, what is an endemic? Endemic is presence of infectious agent constantly throughout the year. It can be one case also, but presence of an infectious agent or the disease constantly in a geographical area for throughout the year. So immunity, the resistance is developed only after years of exposure. And the social factors, lymphatic filariasis is associated with three things here: poor sanitation, urbanization, migration of people. Migration of people. So environmental factors, climate, breeding of mosquitoes, their longevity and development of parasites. It infects, like the climate is responsible for breeding of mosquitoes, and for the longevity means the age of the mosquito and the development of parasite. So maximum prevalence of mosquito was seen between 22 to 38 degrees, 22 to 38 degrees, and a relative humidity of 70%. It is more common in places where humidity is more. It is more common in places where the humidity is more. Drainage, vectors breed profusely in polluted water. As we spoke, Culex is responsible for Bancroftian filariasis. Bancroftian filariasis is responsible for 90%, that is Wuchereria bancrofti is responsible for 90% of infections. So Bancroftian filariasis is transmitted by Culex, and this Culex breeds in polluted water, polluted, not clean water. It is polluted water. And the town planning, inadequate sewage disposal and lack of town planning have aggravated, because the polluted water gets stagnated, the polluted water gets stagnated, no drainage, no proper drainage area, and hence it is a risk factor. So common breeding places are open ditches, septic tanks, ill-maintained drains where water gets stagnant, water does not flow. So what's the incidence? Over 882 million people in 44 countries worldwide are threatened or remain at risk of lymphatic filariasis. So it's endemic in many tropical and subtropical countries, as you can see on the map there: Africa, Asia, Western Pacific, and parts of America. Even America is the South America is not spared. So that 44 countries have lymphatic filariasis as an endemic. In India, it is more common in UP, Bihar, Jharkhand, Andhra Pradesh, Orissa, Tamil Nadu, Kerala, and Gujarat. So these are the places where it has been reportedly extensively in Uttar Pradesh, Bihar, Jharkhand, Andhra, Orissa, Tamil Nadu, Kerala, and Gujarat. So next is clinical manifestations, symptoms. As you can see, it can present with wide range of clinical symptoms, including acute inflammation, chronic lymphedema, and hydrocele. The picture in the left, this is the lymphadenitis. This is the lymphadenitis. So this is the lymphadenitis, and this is the hydrocele. This is the hydrocele. So these are the common presentations. The initial stage is often asymptomatic. Initially it is asymptomatic. It followed by episodes of painful swollen lymph nodes and fever and painful swollen lymph nodes. Then it goes for this chronic lymphadenitis, and then later stages can lead to permanent lymphedema, lymphadenesis of the limbs. This is the thing which you are seeing there in the left side, and hydrocele of the scrotum or breasts. These advanced manifestations can severely impact the patient's quality of life and lead to social stigma. So these are the symptoms and clinical signs. What are the stages of lymphatic filariasis? There are three stages: microfilarial stage, acute lymphangitis and lymphedema. Microfilarial stage, acute lymphangitis and lymphedema. So we have displayed one CDC slide of Wuchereria bancrofti, that is mosquito takes a blood meal. You can see 1, 2, 3 there. Then adults in lymphatics, and then after that adults produce sheathed microfilariae that migrate into lymphatic and peripheral blood circulation. So you can see here, this is the first stage. The second stage here, adults in lymphatics. The third stage, adults produce sheathed microfilariae that migrate into lymphatic and peripheral blood system. Fourth is mosquito takes a meal and ingests microfilariae. And then fifth is microfilariae shed sheaths, penetrate mosquitoes midgut and migrate to thoracic muscle here. Then sixth one is larva, L1 larva. Seventh one is again the larvae becomes mature. Eighth is migration to mosquito head and proboscis, and the cycle continues. This is the cycle of microfilariae in the human blood. So microfilariae, microscopic worms, they circulate in the bloodstream often without symptoms in the first stage. In the second stage, inflammation of lymphatic vessels causes painful swelling, fever and other acute symptoms. And the third stage, lymph builds up, leads to chronic swelling, typically in the limbs, genitals or breasts. Limbs, genitals and breasts. These are the three areas affected. The limbs, where it can cause lymphadenitis or lymphedema. Then the genitals, where it can cause hydrocele, and even the breast. So these are the three places where the symptoms or the manifestations can be seen. So diagnosis and screening, this is done by blood tests that detect the presence of parasitic worms or their antigens. As I said, if you need to detect the microfilariae in the blood, you need to draw out the blood at after 10 p.m. That is after 10 p.m. to 2 a.m. These microfilariae are released in the bloodstream. They are active in the bloodstream at that time. So thick blood smears, ELISA enzyme-linked immunosorbent assay, and rapid diagnostic tests are commonly used as screening methods. So the blood smear constitutes the standard one. So regular screening is critical for early detection and management of the disease, especially in endemic region. So as you see here, detection of microfilariae, methods of examination, blood microscopy, DEC provocation test. You give DEC and then these get provocated and they come into the bloodstream. So DEC provocation test, QBC quantitative Buffy coat, urine microscopy, and microscopy of hydrocele fluid and lymph node aspiration. So these are the methods, direct evidence. Indirectly, so blood microscopy, microfilariae of Wuchereria bancrofti circulate in the peripheral blood. Nocturnal periodicity, that's 10 p.m. to 2 a.m. Blood is collected at that time, and then non-periodic microfilariae, the blood may be taken at any time, preferably in the morning, but still you will not be able to find out the microfilariae in the blood because they are released or they are active at 10 a.m. to 2 a.m., 10 p.m. to 2 a.m. or 4 a.m., whatever the night. It is nocturnal period. Till light is there, they are active in the blood, and after that again they disappear from the bloodstream and get into the lymphatic tissue. So microfilariae are not found in the peripheral blood in the following conditions. When a person goes for elephantiasis, that is a complication of microfilariae, elephantiasis, then microfilariae are not found in the blood cells or bloodstream because of lymphatic obstruction. Because it comes from lymph to the blood. So when there is lymphatic obstruction because of elephantiasis, the microfilariae are trapped in the lymph and they do not enter the bloodstream. And after an attack of lymphangitis, once attack of lymphangitis occurs, adult worm dies. When the adult worm dies, there is the adult form does not give birth to microfilaria, so that microfilaria also disappear. They are not found and then due to allergic manifestations and occult filariasis, in these conditions microfilaria are not found in the blood. So prevention strategies. Three main prevention strategies: vector control, mass drug administration, and targeted treatment. So you can see there the enhanced strategies for elimination of lymphatic enhanced. So we can see vector control, the first one. Second is mass drug administration. The vector control, it reduces mosquito population through insecticide spraying, bed net distribution, and environmental management to limit mosquito breeding sites. That is, clear of the polluted water, clear of the stagnant polluted water. So drain management has to be, you need to drain the stagnant water, the polluted water, and keep it flowing. Then only the mosquitoes cannot breed. That is Culex mosquito, which is responsible for Rogeria bancrofti. They cannot breed. They are unable to breed because of the flowing of the water. If the water gets stagnant, they breed, and then they are responsible for transmission of this Rogeria bancrofti. So that is, and along with that we can do insecticide spraying and personal protection by providing the bed nets. Mass drug administration with antimalarial drugs to entire at-risk population to interrupt the transmission. Mass drug administration with DEC, diethyl carbamazine. So DEC is given as mass drug administration to the whole population which is at risk. So an effective strategy. Then targeted treatment, identifying and treating infected individuals to reduce the reservoir of parasites and prevent further spread. So to reduce the reservoir of parasites and prevent further spread, we target that person who has this one with the different drugs like ivermectin, DEC, and albendazole. These are given to as a targeted prevention. Then mass drug administration. What is mass drug administration? We cover this topic in 4 different headings. That is coordinated approach, annual mass treatment, drug regimens, high coverage targets. MDA, mass drug administration, involves the coordinated distribution of preventive chemotherapy drugs to entire at-risk population. That is mass drug administration. We give DEC or diethyl carbamazine to the populations which are at risk. Okay, then annual mass treatment. This is done annually. These programs typically involve annual mass treatment campaigns that aim to interrupt transmission and reduce disease burden. So annually 1 dose of DEC is given to the population of which is at risk. The entire population at risk is given 1 dose of DEC at the dose of 6 to 12 milligram per kg body weight. So this is given for the entire population. Then the drug regimens commonly used in MDA include ivermectin, albendazole, and DEC, diethyl carbamazine. So you remember these 3 drugs which are effective in filariasis, but once there are complications, those complications cannot be reversed, because no elephantiasis there is obstruction of lymphatic circulation. So at that time it's difficult. They try to reverse by surgery and other things, but results have not been so good. So the high coverage area, successful multi-drug administration programs aim to achieve high coverage rates. They target over more than 65% of the eligible population. So that is regarding. So mass drug administration, all members of community are covered. No need for any blood examination. All, irrespective of whether a person has a disease or not, they are given these 3 drugs: DEC, albendazole, and ivermectin. Then effective 12 days DEC therapy, a single dose is given for 12 days, and then lesser side effects and less complicated process. No side effects, only for 12 days annually, every time, once in a year, for 12 days these are given. So that's the advantages. It avoids the cost of mass blood exam. All members of community receive treatment. Nobody is feels left out. It is effective as 12 days DEC therapy. Lesser side effects, enhancing public compliance. It involves decreased delivery cost, does not require complex management structure. So targeted treatment approach, as we said, the fourth one in MDA. So the targeted drugs, adjuvant therapy, and individualized care. So specific antiviral drugs like the three DEC and ivermectin along with albendazole are used to target and kill the parasitic worms causing lymphatic filariasis. Then adjuvant therapy, antibiotics and anti-inflammatories can be used along with these anti-parasitic. The anti-parasitic drugs are ivermectin, albendazole and DEC. Along with that, anti-inflammatories, also anti-inflammatory infection also, anti-inflammatory drugs also can be used. Along with antibiotics to reduce secondary infection is also advocated. So individualized care for each person, it is different. The dosage is different. The duration is different. So for that, it should be tailor-made for each person. That is called individualized care. So as you see there, onchocerciasis, the ivermectin is given to 150 to 200 micrograms per kg, and lymphatic filariasis is 6 milligram per kg body weight DEC, and albendazole 400 milligrams. And different tables are there that you need to remember. So no scope for explanation in this lecture. So management of lymphedema in lymphatic filariasis, it has different here. It limb washing, wound care, foot care, suitable footwear, physiotherapy and exercise, and therapy for acute episodes. Along with that, limb elevation, skin care. So keep the affected limb elevated above the level of heart to reduce swelling and fluid accumulation. Then the skin care, maintain good hygiene and moisturize the skin to prevent infections and further lymphatic damage. Then use compression bandages, compression socks, so that the lymph does not get accumulated, to improve lymphatic drainage and reduce swelling. And finally, mild exercise to be performed to stimulate lymphatic flow and maintain muscle strength. So lymphedema management, as you see there, uncomplicated acute dermatolymphangioadenitis, uncomplicated ADLA, acute dermatolymphangioadenitis, needs to be treated by giving analgesic, that is paracetamol 1 gram 3 to 4 times a day. Oral antibiotic, if you want, you can give penicillin. If a person is allergic to penicillin, erythromycin is given. Clean the limb with antiseptic, check for any wounds, cuts, abscesses. Can put antibiotic cream or antifungal cream. So management of hydrocele in lymphatic filariasis. Hydrocele is a fluid buildup in the scrotum, commonly a complication of lymphatic filariasis. Effective management involves surgical intervention and conservative treatments to reduce the swelling and discomfort. So you can see some words which have been repeated. So during editing, it has been overlooked. So hydrocele management, they are you are referred for diagnosis and surgery done. Men have a good prognosis with early hydrocele. In men it is hydrocele, and in female the breasts are involved. So these are the complications. The complications are elephantiasis and hydrocele of in scrotum in males and breast in females. So they are they are managed surgically. So in addition to surgery, conservative treatment like scrotal support, diuretics and anti-inflammatory. Scrotal support, diuretics, anti-inflammatory conditions can help management, and anti-inflammatory medications can help to manage hydrocele and improve the patient's quality of life. So as you see, in endemic regions, over 30,000 hydrocele surgeries are performed annually. So you can see the magnitude. 44 countries, 30,000, minimum of 30,000 of hydrocele surgeries are done. So complications are, hydrocele surgery has an impressive 85% success rate. So once the surgery is done, hydrocele can be reduced in around 85% of the people. Filaria survey. It is done for routine survey or survey for evaluation. The NICD standard is to examine 5 to 7% of the population for routine surveys and 20% for evaluation studies. It involves it involves 5 stages: mass blood survey, clinical survey, serological tests, xenodiagnosis, and entomological survey. Mass blood survey, it depends on demonstration. As we said, the blood is rich in microfilaria in the night, that is nocturnal periodicity. At that time, blood has to be drawn. So mass blood examination, it is in at least 5 to 7% of people. This has to be done. So thick film, most commonly used method, 20 cubic millimeter of blood is collected by deep finger prick between 8:30 p.m. or if it is better after 10 p.m. till 10 to 2. Some studies say it is 8:30 to 12. Some studies say it is 10 to 2, and some studies say it is 10 to 4. So it's better to collect at somewhere at around 11 o'clock, because it confirms in all the studies that microfilaria is predominantly present in the bloodstream during that time. So the blood films are dehemoglobinised, that is, hemoglobin is removed, stained, dried, and examined for microfilaria under low power. So microfilaria can be seen under the microscope in a thick smear. Remember that it is thick smear and not a thin smear. So it is thick smear. So you can see this thick smear. So 20 cubic millimeter of blood is taken. So membrane filtration concentration, that is also called MFC, most sensitive method for detecting low density microfilaria. DEC provocation test, MF can be induced to appear in blood. See, in the night time they occur, they come out from the lymph, come to the bloodstream, enjoy and go back. Okay, I'm saying enjoy because they enjoy, not the human. The microfilaria, they enjoy in the bloodstream and then they go back. You can think that they come to the swimming pool, swim and then go back. So to bring them in the morning, we need to give 100 milligrams of DEC, diethyl carbamazine. That in the daytime, it brings the microfilaria. Within 15 minutes, they come to the bloodstream, and then blood can be collected at that time. From 15 minutes to 2 hours, they are in the bloodstream, and again they go back to the lymphatic system. So clinical survey, people are examined for clinical manifestation of filariasis, that is lymphedema, fever, swelling in the lymph nodes. All these things can be examined. Serological tests to detect antibodies to MF, microfilaria, and adults using immunofluorescent and complement fixing techniques. Using these two techniques, we can do a serological diagnosis, but cannot distinguish between past and present infections, heavy and light parasite loads. So serological diagnosis cannot differentiate between these two, whether it's a present infection or past infection. Xenodiagnosis, mosquitoes are allowed to feed on the patient and then dissected 2 weeks later. Mosquitoes, this is called xenodiagnosis. The mosquitoes are allowed to feed. Culex mosquitoes are allowed to feed, and then they are captured and kept for 2 weeks, and after 2 weeks they are dissected to check for microfilaria in their in their body, in the body of the mosquito 2 weeks later. So entomological survey consists of general mosquito collection from houses, dissection of female vector species for detection of developmental forms of the parasite, study of the extent and type of breeding places. Breeding places, as I said, they are commonly seen in polluted water. So study whether polluted water is stagnant in and around the house. So thank you. That was the topic which has been covered for the part of lecture. If there are any suggestions, you can put it in the comments below, or you can directly tell me whenever I take a class in the college. Thank you.